I
We can edit anything, doesn't matter. Oh, hey,
yeah,
Chris.
Hey Chuck, how are you?
It's a really special night. I'm fantastic.
Absolutely. It's a weeknight. We're recording. We have a special guest with us. We mentioned a couple times on the air how we wanted to do an episode about responsible green surgery because we are, as a department, undergoing the development of a new procedure room at a new site we're going to. And spontaneously, multiple people have written in requesting and suggesting this particular guest.
Yes. So we are thrilled to have Mark Baratz join us from Pittsburgh and the University of Pittsburgh. And I could spend a long time singing Mark's accolades. Not singing, I shouldn't say that in front of him because he is a musician, but acclaiming in many ways. But I'll just say that he's the fellowship director and has been for a number of years in different capacities. But Mark is an amazing educator, leader, a speaker, and apparently really knowledgeable about practicing green surgery. So, welcome to our podcast.
well, thanks. You guys must have talked to my mom because that's really nice things. I appreciate it.
Yeah, that's exactly one of the lines that I use when patients say
Yeah,
nice things about me. So I want to go tell
right.
my mom and they eat that
That's
up.
right. Yeah,
But thanks for joining us, Mark.
sure.
Before we dive into the topic about green surgery and environmental responsibility as a surgeon, um, I think you were mentioning something really cool that you guys do in your fellowship, which is a book club.
Yeah. So we try to do two or three books a year that are non-medical. We always do the same book as the first book every year. It's called The Confidence Code. It's written by two women who examine both the science and social science of why women in general are reluctant to apply for jobs that they're eminently qualified for, reluctant to ask for promotions, to ask for raises. And it's a fascinating book. In any given year, our program is either half women, or in this particular year, there's only one. And the men, I think, enjoy it because they say, "Yeah, actually, I suffer from some of the same imposter syndrome, questions about my worth in my own dealings with people who are my superiors." So it's a great book to do as a man or woman who wants to be more thoughtful about how people think and work. And then
Sounds,
after, yeah,
no, keep going.
no, and then after that, we just pick fun books. So there's one book that I love that was called the Wave, and it was about waves from the perspective of geologists, meteorologists, the shipping industry, and big wave surfers. So it's important for the shipping industry because most of our ships, our cargo ships, were designed for waves that are 100 feet or less. And now we're having swells that are well over that. So there's billions of dollars in loss. And then big wave surfers. And whenever we do this, I always try to have a guest. So for Confidence Code, I've had Robin West, who's the first woman to be team doctor for two major league sports teams, baseball and football, and president of UPMC. And then for the wave, we had this guy named Twiggy, who's a big wave surfer from South Africa,
That's
who
awesome.
who called in, and it was serendipitous. But we did the book club in February, and a month previously, he was the surfer who paddled into the biggest wave that anyone had caught that year. So typically, these surfers are pulled into waves by wave runners. He
Yeah.
paddled into like an 80 footer at age 41,
Oh,
right? So pretty crazy, but it's a fun thing. It's a great distraction. I personally believe reading is just a really important thing for wellness and keeping a good perspective on things and being educated.
Oh my God. I could not agree more. And I've actually been thinking about a non-medical book club, and I love to hear that you're doing it. You're usually a couple steps ahead. I'll talk about two books very briefly before Chris kills me. One, my favorite book that I gift our fellows is How Will You Measure Your Life by Clayton Christensen. It is my absolute favorite, and it's kind of a going away gift. it's just been very impactful for me. Um, and I could talk forever about that. I won't. But another person who likes that book is our partner Marty Boyer, and he espouses it to the residents and fellows as well. But interestingly, Marty and I read different things, and he gave me a book to read that he just read that won the Booker Prize called Flesh. And
Hmm.
Flesh is not my normal genre, and it's not crazy. It sounds like it could be, but his it's by David Saloy. Won the Booker Prize, and so that's amazing. It's fiction. I don't really usually read fiction, and it is, I should read more fiction. Is my takeaway. It's really entertaining. It's so different, so well written that I highly recommend. I'm not done with it, but it's really a very different book for me. So I recommend it.
I wrote them down. I'm excited.
And we'll make sure to put those in the show notes for sure, right, Chuck?
Yeah.
Yes. You notice, Mark, that I'm the technician on this podcast. Chris just shows up and looks good. I do all the work behind the scenes.
It's really hard. It's really hard to man this email account as well, Chuck. So, so Mark, we wanted your advice. So as a department, we're moving to a new site, and we have not in the past done anything in the office, with the exception of a brief moment where, during one of the pandemic related shutdowns, we did probably about somewhere between 20 to 30 carpal tunnels and triggers in the office because we didn't have access to our surgery center. But we're starting a new site, and within that orthopedic suite, there's going to be a procedure room, two procedure rooms, both of them used by our physiatry colleagues for image guided injections, but one of which will be outfitted for things like Wallant surgery, so wide awake local anesthesia and a tourniquet. What kind of high level advice would you give us in terms of how to start thinking about doing this, what the upsides are, what the potential challenges are going to be, and some context of your journey with thinking about such ventures?
Yeah, so it's a great question. And unfortunately, I'm not the best person to ask for that because at various points in 2013, when I came to UPMC, I was very intent on having a procedure room and was unable to get that. One of the issues that people have to consider when they're approaching their practice or the institution is where that organization is with respect to cost and revenue. So when I came to UPMC, they were in a cost sensitive mode, and they were very interested in a lot of my sustainability initiatives, including procedure rooms. But shortly after that, they got into some negotiations that made it very favorable for them to not do cases in procedure rooms, um, and became revenue sensitive. And so I grew up in the area where everyone wanted to generate as much revenue as possible. It's a sad reality of how things work. And so when you do things in a procedure room, as you know, you don't get a facility fee. And so if you're in an institution that has a surplus of OR rooms in surgery centers or in the OR, there's a disincentive for them to do procedure rooms because you're not going to get a facility fee, but you're still going to have to pay for the resources that are necessary to do that operation. And so, unfortunately, it's not something that I've been able to put into place. But the real heroes in sustainability are doing stuff in procedure rooms because there's such a great opportunity to reduce your footprint. In general, if I talk to my institution about, oh, this would be such a good way to have a more sustainable approach to this problem. They look at the differences when we've studied. Look at the difference. They go, Mark, that's so nice that you care about the planet, right? If I say to them, this is something that is going to save you $750,000 a year, and by the way, it's also a great thing for the planet. They go, oh, really? So there's this constant struggle in medicine between cost, revenue, and what is the right thing to do. And fortunately, right now, most institutions are in and most communities are in a cost sensitive mode. And frankly, that's the future for our trainees and the young docs that are listening to this podcast, right? They are not going to be paid more for their services. So their way through this is going to be with efficiencies, and all of those efficiencies are good for the planet. So the person to talk to about setting up a procedure room are people like Paige Fox, who wrote a beautiful article in the Journal of Hand Surgery, David Ring, who did this a lot when he had a community in Austin, Texas, that was a uninsured population that he couldn't get to the operating room. Don Lalonde, who did this for a big part of his career, primarily because he got kicked out of the main ORs in Canada. He didn't have a choice. And so rather than bemoan the fact, he embraced it and did not invent Wallet, but popularized it and gave us a lot of good strategies. But your initiative or your foray into this, I applaud both you and your institution because it's a big deal.
It's thank you, and we're going to push more on that topic of being environmentally conscious. It is interesting to your point of the next generation. You know, a couple, as you both know, a couple of things are changing. You know, site neutral payments are coming from CMS, and we presume that private payers are going to follow suit. And increasingly, but really slowly, insurance companies are paying more for surgery done in the office setting. And so there is hope that we can both, as surgeons, do well on the revenue side and the expense side, but our partner institutions, for those of us in large institutions, they are at risk here.
Absolutely.
So tell us about, and I think you have done work on environmentally conscious surgery in the main ORs. What's your general philosophy? Why would Dr. John Fowler recommend you strongly for this podcast?
Well, before he answers that, it's not only John Fowler. It was Bob Vandermark and one of your former fellows, Etka, who mentioned that you would be. We never had three separate people write in
No.
for a guest. So that's super impressive.
Well, thank you for that. So, um, sort of there are three things that I think need to happen for there to be a shift in the way we look at things. And so the first thing is you have to care about it. The second thing is you have to be curious about it. And the third thing is you have to learn about QI. So, as is the case with most people in academic medicine, my goal and my interest in the things that got me excited about coming to work was working with young people. And part of that was doing basic science research. And so I did a lot of that early on in my career. It shifted to some clinical stuff, it shifted to some anatomic work. And now we're super lucky at the University of Pittsburgh to have somebody like John Fowler, who loves research for the sake of research, which is just a rare thing in most people. What I started to realize when I got more interested in sustainability is that many of our fellows would not do either basic science or clinical research when they graduated. But there isn't a doctor, a surgeon in this next generation that shouldn't do QI. So about 15 years ago, I required all of our fellows to do a QI project. And they got to pick the topic. Some of them would work together. And it's been a very fun and impactful thing because one, they do care. I mean, for them, for this generation, they know what is at stake. They know that they're in a different paradigm than Chris, you, me, and Chuck were in, and it's important to them. And so they care. Once you start to guide them to some of the questions, they become more curious. And so the final thing is teaching them about QI, and QI, or quality improvement, is a vehicle for change. So if there's something you see that you don't like and you want to change, it's a way to do that. And the engine for that vehicle is life cycle assessment. So if you really want to look at a question and say, well, what's better for me to do? Is it better for me to have something that's disposable, or is it better for me to have something that's reusable? Should I use a cotton gown? Should I use a paper gown? The life cycle assessment is really the way to do that, because it's cradle to grave. It looks at what it costs to produce that, it looks at what it costs to use it, and what it costs to dispose of it. And what's cool now is that there are a lot of databases that make it easy for people to do that. If I were going to recommend that someone in an academic center or someone in private practice got interested in this, I would reach out to uh, people in sustainability who are engineers, because there are many experts in this, and it is fascinating. And so you can pick a million things. We looked at using a Kleenex versus a 4x4 when you're giving injections. We looked at throughput in our ORs for cases that were done under local anesthesia versus local and sedation. We looked at the difference between scheduling a case under local and scheduling a case under sedation. And not surprisingly, there was a difference, and it wasn't distance difference actually in someone doing the scheduling per se. It was following up on labs, the time to follow up on labs. So the beauty of your procedure room is that it streamlines things. And when we looked at one process, how long it took someone to enter the door of our facility and leave the door of our facility with the same procedure done under local or done under local sedation over the course of a year, I saved 320 hours by doing those cases, the same number of cases under local versus an associate of mine who did them under sedation. So Chris, what would you do with an extra 320 hours in a year, right? Or Chuck, what would you do? You could do more cases if you wanted to be more productive. You could get home to your family. You could read a book. You could do any of a variety of things. But these differences are tangible. And learning how the process works is a big deal.
So I have a comment, a very important comment and a question. My important
Sure.
comment is something you said that's highly controversial that you don't even realize. And that is you lumped you, me, and Chris into the same generation. And Chris is highly offended right now because he sees himself
I am
as a
honored. I am
different
honored.
generation. That's his,
It's
you
like
know, he's so much younger than us.
Kobe and Jordan. It's okay.
I love what you said, and I guess my follow-up question is if I walked into your operating room, what and this is a hard question because we've talked about and I would love to operate with you sometime, but we've never done it. What might I see that you do that is a more sustainable practice? Again, a hard question to answer, but I'm sure that through some of these QI projects there have been long-lasting changes.
Yeah, so the biggest thing is minimal draping. So we try to keep drapes to a minimum. That doesn't always hit our bottom line because the companies that provide those supplies are very good at manipulating cost. But from a waste generation, it's way less. You'll see almost no plastic on my field. So we've eliminated almost all plastic from the field. We don't use light handles for little cases, for carpal tunnel, trigger fingers, a lot of those different things. And then something that you might not see in the OR, but you'll see at my farm and you'll see in our lab is that we do a lot of reclamation. So the at our surgery center, one of the coolest things is to get the people together in your surgery center, get all the scrub nurses and the nurses together for a meeting. And when that meeting starts, they're all going to be there saying, okay, what did I do wrong? Because what does a physician do when he gathers together people that work in the OR? They complain about something, right? And so when you walk in the room, you go, I need your help. I'd like you to help me figure out a way to use less stuff and throw less stuff away. And you should see their faces light up because it's
Because
cool
they
for them. First, you're not yelling at them. and two, you're engaging them. And the first time I did that, they said, "Oh, Dr. Barris, you don't use this most of the time, and we could get rid of this." And they did most of the lifting on this. So we use less, and then they also know that anything that isn't used, we practice ask before you open. So if there's something that's important to you, you have it in the room, but don't open it, right? Because it saves money and it saves processing, it saves time. Um, but anything that is used, or anything that's like a pack gets a rip in it and they have to throw it away, they put it in a corner. And there are drapes and cords and all this different stuff. And in my barn right now, the floor and all the stuff in the barn is covered with these drapes because birds come in to my barn and they nest and they poop. And so rather than cleaning it every week, I put these drapes down. And we collect all the bovie cords. And last year and this year, that was one of the fellows QI projects. And I sold a bunch of it to a scrap store. And I told the fellows that with the money that I get from all these cords, we're going to throw a party. I got $57. It's going to be a big party. So, but those cords have copper in them, and that copper has value. If you strip it, it's $5 a pound. If you don't strip it, it's $1 a pound. So yeah, so
Awesome.
there's stuff in view and there's stuff on the fringe, and then we just try to use less stuff.
It's so you hit on so many important things. On this podcast we've talked about. I went down to Atlanta to learn from a surgeon who's very efficient in the total joint space, and there's so much preaching about lean trays, lean packs, to the points that you made. And we went through some of the same exercises you have, but what we haven't done, and we will now, is gather the nurses because they have so much experience and they know exactly what we use and what we don't use. So it's a wonderful suggestion and engaging, obviously.
Yeah, a
Yep,
lot, a lot of nurses are making away with stacks of blue towels, I've noticed. So
good.
at least they're being used, right? You
You
know?
don't want to throw it away.
Yeah, I thought about you today because we had an unfortunate situation where we were setting up a case and the bovie, which had not been set up yet, was fell to the ground. And your fellow who wrote in to nominate you, Etka Kurakan, mentioned that you're using the bovie cords for copper. I was like, maybe there is something we can do with this now, other than
Yeah,
just discarding it.
The great state of Missouri passed a law that for every bow, you can no longer have a regular bovie, you had to have a suction bovie. And I have no idea if that's the case in Pennsylvania. It kind of reminds me of gas stations, which I do not frequent with my electric car, and that gives me joy. Some gas stations have the suction on the thingy, and some don't. Alabama, of course, where I grew up, has no. There's no concerns about fumes from the gas pump. But so now in Missouri, you have to have these suction bovies. Not only are they bigger and clunkier, they cost more. And we've gone to reusable bipolars, which I don't love personally, but I love the fact that we're not open bovies.
it's huge.
It is
Yeah.
nice not to smell the smoke because I was annoyed by this change at first, and then it wasn't working one time. I was like, man, I haven't smelled that in a long time. It's probably not good for me.
The
No.
key thing with that is that the smoke is captured, because in some of those you have this expensive device that then is just vented normally. And so it's there is an advantage, but the real high end suction bovies, that gas is contained and not released into the room.
So just one, I wanted to ask maybe just one practical thing. You mentioned about your draping being very minimal. Are you using kind of the standard drapes that we would throw away at the end, or are you using drapes that going through your life cycle audit earlier? Are they using drapes that can be washed? Like exactly walk me through how you would drape for a carpal tunnel surgery.
Yeah, so right now there's a down drape. I actually found a drape that is used for spinal taps, and so it's a relatively a small rectangle, and then a second a straight up drape. So as opposed to the extremity drapes that cover the entire body or full length. These are much smaller, much less weight, less plastic. Uh, I was so proud of myself. I'd used this for 10 or 11 years, and one of my colleagues said, the nurses hate those. So I said, actually, they were afraid to tell me. Um, and so
It's because you had one of those
we're
meetings where you sat him down and
right,
yelled at him.
right. So we're looking at fine tuning that, but it's you can if you take the time to look at what is available. There's some pediatric drapes that are significantly smaller, and the truth is that Don Milan showed us that you barely need to drape. He uses 2 blue towels, right? But yeah, all of these things are meat resistance, and that's another obstacle to sustainable actions. Is that there are rules that don't have a basis in science, and they are costly and they are wasteful. And so QI is the way for you to combat that. Um, Important process to be able to work through.
Yeah, for sure. And Chris and I don't work in the same setting, and I don't know, Chris, if we even use the same local pack. Um, but we've done many or most of the things which you suggest: no light handles, no extremity drapes, very limited draping. I got last week. I got so frustrated. Not it is what it is. But I walked in. There was a new nurse who'd opened a regular pack, and it's $30 more, which is part of it, and it's a lot more waste. But it's these things feel good to me, um, because I know we're doing good things, even though I know we can also do better.
I have a confession to make. I still use light handles. And maybe
Ooh,
I'm publicly putting it out there that I still
wow,
use them.
Chris,
So now I'm accountable.
that is
I
so
always
brave.
hold my feet to the fire. But to your point about QI, Mark, I mean, when during one of the pandemic shutdowns, WashU required the med students to all do a QI project. And one of the med students going in orthopedics came to me and said, "Can we do something?" And she had read one of the articles about, and probably yours, about, sustainability. And we cut down our draping and redesigned a complete local only pack, which I think Chuck had been using at some point and maybe still does. That eliminated a lot of the stuff that was not useful, and it cut the price substantially, and decreased the waste. And I think there's probably still more we can do to hone that down. So as we look at this kind of next phase for our department, at least, again, it's a nice opportunity, and I think it's great that your fellows participate in those QI projects, as it's part of the culture in your program.
Glad you mentioned the pandemic, because I have to say that that's the other place where these sustainable activities shine. So you have a pandemic. It's hard to treat people who may or may not have a condition, a disease that is contagious. It is so much easier to provide their care under local anesthesia. The other thing that the pandemic showed us is what happens when you're resource poor, when you don't have enough nurse anesthetists, when you don't have enough anesthesiologists. And you can do a lot of this work in your own silo without that support. Another example is, dramatic weather events. When a hurricane wiped out the Baxter plant in North Carolina and in Puerto Rico, and we had an issue with saline, right? Uh, you don't need an IV. During the pandemic, there were shortages of medications, right? And so, for the future, this is just such a smart strategy for young surgeons.
Yeah.
What do you think the next big opportunity is that you see? You don't have to give us solutions, but what do you see as coming
Yeah,
in hand surgery?
yeah. So I just there's a guy named Steve Kohler who is up in New York, and um, he's actually during the pandemic had a lot of people who had very significant injuries. He was doing both bone forearm fractures under local anesthesia. He's pushed the envelope a lot on uh, pre and perioperative antibiotics does not use antibiotics for distal radius fractures, for a lot of fracture work, and has shown no difference. So we just have to, I think, look at every resource we use and question it. There's so many things that I do that I learned early in my career that I continue to do without questioning. And so it's fun to be around people who, as I said in the beginning, care and are curious, because then all of a sudden you get these frame shifts in how you think and work.
It's funny you mentioned Steve Kohler. Shout out to Steve. I was just with him yesterday for a Hand Society thing.
Oh,
And
nice.
he is one of the few people who has stood up to the ALRN guidelines with regards to nursing requirements during hospital-based procedures.
Right. And he's on the
And
board. He got on the board,
I did not realize that.
which is massive, right?
Yeah, that's
Because they would come up with these arbitrary guidelines and without having any scientific basis to it. And Steve bristled and then petitioned, and he's on the board.
fantastic. Well,
Yeah,
hand surgeon advocacy at its finest.
Exactly right. I have maybe, I'm not sure, maybe one last question. Chris may have one, but I don't want to, this could be a huge one. It's not intended to be. I am guessing that your overseas work, your mission work, if you want to call it, has also taught you in this domain about doing more with less and how to be smart about things. Is that true? And any lessons to share there?
yeah, it's absolutely true. I mean, the gift that we have as hand surgeons are that there are so many procedures and so many ways that we can help people with a fork and knife. So with very basic surgical instruments, we can do some very powerful things to preserve or restore a limb. And because infection in general is relatively uncommon, we can do things with lower levels of draping and uh, less aggressive use of antibiotics. I have a close friend who I work with at the University of Pittsburgh, Noe Woods, who's an OB-GYN, and she has a colleague who travels to Kenya every year and is doing hysterectomies with minimal draping, uh, very limited instrumentation, none of which is disposable. All of it is reusable. And she's come back to McGee Women's Hospital and adopting those practices at McGee Women's Hospital and looking at outcomes. So it's such an important question because in every metric that anyone has ever used to compare medical care in the United States versus other countries, we don't look that great. We spend a lot more and our outcomes and our health is not necessarily improved. So I think it's you raise a really, really important point. Again, that's going back to the other question, what do you see on the horizon? Lessons from other people, right?
So this is just really, really refreshing conversation with you, Mark. I can see why so many people think so highly of you in this domain. So I appreciate you taking the time to join us. I wanted to close out with one clinical question, maybe.
Sure.
So can you, and I'll give you, Chuck, maybe you can respond to give Mark a little time to think. Is there one thing, one procedure, or one step of a procedure that you did when you were, say, just 10, 11 years in practice versus that you don't do now?
Um, yeah, that's such a good question. I think the biggest change in how I look at my practice has come from doing stuff under local. So when I'm talking to patients early on, I was so enthusiastic about this that I talked people into doing stuff under local that I probably shouldn't have. So people that are exceptionally anxious are maybe not the best candidates for it. But now when I talk to somebody, I say, you know, one of the differences with me doing this under local anesthesia is it's going to let me test drive your operation. So it's going to let me test drive your trigger finger, test drive your flexor tendon repair, fixation. I did a P1 fracture today under local anesthesia so that I could make sure that the alignment was appropriate. Uh, there's so many procedures that I just was taught and chose to do with people asleep that I now see the value in. Well, let's move that. Let's see if that tendon gaps. Let's see if that finger lines up with the fracture fixation that I've chosen. I think that's probably the biggest thing that I do now that I didn't do.
I love that. And that is a great way to close. We are grateful for your time, for your expertise, for your thoughts. And I'm going to take this book club to heart. I love that you're doing it, and it cements the idea of moving forward. So we'll see if I can make it happen.
Thanks so much, and thanks to both of you for doing this. This is extra time away from work, family, things that you like. It's a huge service to our trainees, a huge service to young docs in practice. It's a huge plus for the ASSH. So thank you for doing it and for keeping it going for so long.
Thanks for saying that,
Real,
Mark. We
yeah,
haven't
no, it's
recognized it,
amazing.
but we're well over 250 episodes now. I got an
That's
email
amazing.
recently, so it's a special thing. We enjoy it. Still having a hard time truly understanding it, but thank you for saying that.
Yeah, yeah, no, absolutely true.
Great
Good
night.
night.